Thank you to everyone joining us this afternoon. My name is Liz Owens, and I'm a project coordinator at the Healthcare Improvement Foundation. Today's webinar, entitled Patient Safety and Quality Award 2018, we will hear insights from our 2018 top 10 winners about their award-winning initiatives. We will plan to hold all questions for each presenter until the Q&A session at the end. Just a quick overview of the Delaware Valley Patient Safety and Quality Award Program. HCIF has hosted this program since 2002. We're pleased to announce that in 2018, that's last year, we had 29 entries to this award program from 17 PPC contributing organizations. This program recognizes hospitals, health systems, and other providers for their innovative contributions in advancing patient care, and it promotes best practices in patient safety and quality throughout the region. Lastly, it is funded by the Partnership for Patient Care, PPC. PPC is a collaboration between Independence Blue Cross and the Philadelphia Region's hospitals, and it is managed by HCIF. As you hear from our 2018 winners today, we'd like to remind attendees what the criteria for award entries is. They are to be replicable, innovative, current, collaborative, and have commitment from senior leadership. Just some quick housekeeping items before we get started and hear from our presenters. You can access audio for this webinar through your computer or your telephone. However, all questions must be entered through the Q&A box. You might need to look for this in the menu bar. Our team will be monitoring the chat and Q&A box throughout the webinar if you are having any technical difficulties. Today's webinar will be recorded, and we will send it out to all registered attendees so you can share with your colleagues along with a PDF of today's slides. Additionally, in the next couple of days, you will be receiving a short evaluation via email from myself. We ask that you please take the time to fill out this quick survey. Lastly, there's a poll question in regards to how many people are participating in this webinar with you, and we just ask that you please take a moment to answer. While you listen to our speakers, we would like for you to think about a few things. You'll see up here on the list is the order of our presenters today. We'd like you to pull out some highlights that are important for you to share with your organization, see if you can identify some of the key factors that made these projects successful, and to think about how these projects could be replicated at your own organization. Now, I'd like to remind today's speakers to take a moment to introduce yourself after we announce your name and to please mention your role in the initiative. At this time, we're going to actually start with Mary Ellen Morba from Fox Chase Cancer Center. So at this time, Mary Ellen, we'll hand it off to you. Thank you.
Thank you. Good afternoon, everyone. At Fox Chase, our initiative that we submitted was the improvement of the collection and documentation of advanced directives. This is really part of a larger organizational initiative to improve our program for advanced care planning. But after an initial assessment of where our staff was with kind of culturally approaching the subject with our patients and with their skill level and their confidence in being able to do this, we thought that a good entry step into that umbrella initiative was to focus on the collection of actual healthcare power of attorney documents, which we were sorely lacking in our EMR when we did an initial assessment. We began the project with an assessment of our staff on many levels, not only trying to gauge their willingness and confidence in being able to have conversations and ask patients for these types of documents, but also looking at the ease of access of those documents in our EMR and the types of documents that we were putting into our EMR or giving to our patients to complete to place in our EMR. So our primary goals for this initiative ended up being to improve the collection of the advanced directive documents, either living wills or healthcare power of attorney. And we broke our subgroups into patients who were having surgery, admitted patients, and new outpatients who were newly registered within their first year. And our hope was to improve the amount of power of attorney or living will documents that were actually placed in our EMR for those patients at those milestones in patients' care. We also identified the need to have easier access to the documentation once it was in our EMR. One of our early discoveries was that it was really hard to get to. It was multiple clicks, and where it was being placed in the EMR was really buried and difficult for the provider staff, the clinical staff, to be able to get to. And we also discovered that we had so many versions, even internally, of documents that we were giving to patients. We wanted to be able to standardize that and standardize the information that we gave to our patients and their families about advanced directives. So those goals drove the implementation. We spent a fair amount of time developing a new booklet in conjunction with our risk management department throughout the Temple University Health System. We developed a booklet called Advanced Directive, Your Choice, Your Voice, and it's a beautifully done booklet which is simply explaining advanced directives in lay language, and also has inside the booklet on perforated pages a copy of a living will that they can complete and detach from the booklet, and a copy of the healthcare power of attorney. The process that we created for our staff and the patients was to actually ask the patient for those, give the patient a booklet beginning with their new patient registration, and follow those requests through registration and during their initial visits, also at their pre-op visit and at their admission visit to the hospital, and offer to help them complete it during each of those milestones, and the nursing staff or any of the hospital staff could serve as the witnesses for that. We could immediately take it and scan it into their records. We did a lot of education with our staff in order to help coach them through that process, give them a better understanding of what an advanced directive was, the implications of needing one, and role-playing in order to help them be able to ask for it with the patients. We accomplished a lot. The new booklet was very, very well received, and it is currently stocked at all inpatient and outpatient locations and all procedural locations. We also have it posted on our outpatient portal, and it's available either in paper copies or electronically for patients and for staff throughout the organization. We developed much simpler pathways to be able to get to those documents once they're in the EMR. A hyperlink pops up right in the ribbon when you open the patient's record so that you can see whether or not they have an advanced directive in the record. If they don't, you can ask for it and remind the patient that they need one, and you can also click on that hyperlink and it takes you right to the documents that have been scanned into the records. We scripted the workflow and continue to include that in regular in-services and refreshers for the staff, and we do walking rounds to offer to restock books in all of the areas, and also touch base with the staff to see if they're having any issues, if they're having any pushback from the patients, or if there's anything that has come up that's new that we hadn't anticipated, and we can help them to address and help them to create a process or a script that would help them through uncomfortable situations. We've really had very, very few. I think that more of the fear was on the part of our staff asking about the subject matter. What they found out is, for the most part, the patients did comply. There was very little refusal. What we do get sometimes is, I'd like to take this home and talk to my family about it and bring it back, and sometimes they forget to bring it back, but there has been very little negative pushback and conversations related to the conversation that the staff and the patients have, which I think was the bigger fear among our patients. So in my mind, culturally, we made a huge breakthrough in that we're much more comfortable now having that conversation and asking the patients in what was perceived to be a little bit of a touchy subject matter. I think that we also have always offered and continue to offer workshops for patients. It's something that our risk management department does, and at regular intervals, evening and daytime workshops are held for the patients so that those who have questions can attend and get more information about advanced directives and living wills. We were able to take our data from almost zero compliance with actual documentation scanned into the record up to about between 25 and 30% on a sustainable basis. If we compare ourselves to our peer oncologic hospitals throughout the country, we're pretty much at that same level. Most places have achieved about a 30 to 35% compliance with having documentation in the charts. So although it's not, we think we can do better. We have made a vast improvement from where we started, which was almost no documents at all in the chart. And I think the even bigger improvement that we've made is at least we've dipped our toe in the water to giving our staff some confidence to begin these conversations. Our future goals and things that we've just recently extended to is introducing the Serious Illness Conversation Project to our providers and to our extenders, and beginning to build a template to document advanced care planning components in our medical records so that it's information that everyone who takes care of the patient will have access to and understand what conversations have been had and what our patients' wishes are, so that we can provide concordant care throughout the patient's care that they're receiving from us.
Thank you, Mary Ellen. At this time, we'll hear from Alan Artis. He is from Abington Hospital, Jefferson Health. Alan?
Yes, how you doing? My name is Alan Artis. I am a nurse manager for Abington Jefferson Health Post-Surgical Trauma Unit. I am today talking about our ambulation and WAGS program. WAGS is an acronym that we came up with for walking after general surgery. So we developed this program because during leadership rounds and surgical rounds, we saw that a lot of the post-op patients wasn't walking and ambulating as much as they should, which was also increasing their length of stay. So to initiate this process, and the doctor's offices pre-op, they would let the patients know the expectation of them walking, because most patients, they feel like they had surgery, they need to rest the whole day before they get up, they shouldn't be ambulating, their pain is too much. So we started the education in the doctor's offices first, letting them know the expectations, which would also give them and their families the expectation that we want them to ambulate early. So the first thing this would improve is the patient and family participation in their care. It would also ensure that the patients are ambulating, and if they wasn't ambulating, identify the issues or barriers that was causing them not to ambulate. And with this would decrease their length of stay and decrease their post-op complications, because with them not ambulating, they had the possibilities of developing ileuses or some type of complication, pneumonia, several. So in the beginning, we got all the staff engaged. We developed a sheet that we will put on every surgical patient's door, have all the patients understand why they had this sheet on the door and the importance of ambulating. This program became very successful because we had the support of all the services and surgical teams who would educate the patients pre-op, and then we had the patients ambulating on a regular basis. Some of the factors that made this project successful was, like I said, starting the education before admission and letting the patient know the expectation of them getting out of bed and how this could decrease their length of stay and help them get out of the hospital earlier. When we first developed this program, we only used a sheet of paper on the door, and it was really just motivated through the nursing staff, management, and the surgical team. After the strong development of the program, we also developed a help board, which we kept at the front desk of the nurses station, which we would document on that whiteboard every patient that could be walked and ambulated. This will help not only staff, but the help program who came up and volunteered, that they would go around and take the patients for a walk when staff was too busy. Since the development of this program and entering also adding the therapeutic dogs, we have added therapeutic dogs who come up twice a week. They walk with the patients. You know, patients, they see a dog, they encourage them to walk more. Also, there has been other floors within the hospital. The heart failure unit has also adopted this program to get early ambulation in the heart failure patients. Hospital-wide, they have adopted a whiteboard. Every floor in the hospital now uses a help whiteboard to help direct care from the volunteers who will help patients who need to be walk fed or anything other than nursing care. As you see on, I don't know if you can see on the poster board, that's the ambulation sheet in the middle next to the March 17th. That sheet will go on every patient's door. And then as the patient and families will walk around, they will just document how many feet they walked and who helped them. So it would just give them some independence of their own care. This really improved our length of stay. Patients started to go home at least a day early. We have had less complications, no pulmonary embolisms. I think we had like one patient who had pneumonia, but it decreased our length of stay and our post-op complications. Since the award, we also purchased iPads to start with our new program, which is to collect data on ICOF. Currently, we are collecting data to check our documentation on our employee documentation on ICOF and all the bundle. Right now, our documentation was really low on all the parameters in the bundle program. So the data has showed that we are not documenting properly. Since collecting this data, we have improved our documentation like 60% in every area, and that's and we are showing gradual improvement continuously. The ambulation program has continued to progress. We now not only do it for surgical patients, we do it for trauma patients and any patient that come to LymphS. Originally, we was only doing colorectal, bariatrics, and general surgery. Now we have also included trauma. Early ambulation is the best, even if we're just getting them to the chair every day. These are our goals. That's pretty much our main focus, was making sure to decrease length of stay and decrease post-op complications, and also get the patients involved in their care. And then we increased the use of the therapeutic dogs, which also got the patients to want to walk more.
Thank you, Alan. At this time, we'll now hear from Dr. Parmet. Dr. Jonathan Parmet is from Pennsylvania Hospital. Dr. Parmet.
Hi, good afternoon. My name is Jonathan Parmet. I'm an attending anesthesiologist at Pennsylvania Hospital. I want to share with you a project that we've been working on since 2014. Just as a matter of introduction, patients undergoing coronary artery bypass graft surgery, despite the enormity of the surgery, they fear postoperative mechanical ventilation, and they will express that to you that they definitely do not want to have the endotracheal in place after the surgery. Yet despite this, only 2.9% of patients who undergo coronary artery bypass grafting undergo extubation in the operating room or on-table extubation. In 2014, we initiated an on-table extubation program, and we successfully extubated on the table 48% of patients undergoing coronary artery bypass grafting. However, 50% of those patients ended up on BiPAP in the intensive care unit, either due to inadequate analgesia or profound analgesia. So from 2015 to 2018 until now, we've been trying to hone our skills to develop a multimodal analgesic protocol that would facilitate on-table extubation and that would decrease the use of postoperative BiPAP. In 2015, we began to use intravenous Tylenol when we came off the heart-lung machine. In 2017, we increased our use of preoperative intrathecal narcotic. And in 2017, we introduced the use of gabapentin. And what you can see in the center panel under results is that from 2015 to 2017, there's been an increase in the incidence of on-table extubation. And if you look underneath there, there's been a reduction in the use of post-operative BiPAP in the ICU. A side effect of getting the endotracheal tube out quickly or in the operating room is that we looked at post-operative length of stay, and what we observed was that patients that were extubated in the operating room had a shorter post-operative length of stay. In fact, a significant post-operative length of stay compared to patients that did not undergo on-table extubation. You can see on the final panel that the patients that did not undergo on-table extubation stayed in the hospital for 9 days, whereas patients that underwent on-table extubation their post-operative length of stay was 5.6. If you look at the national average of patients that undergo coronary artery bypass grafting, their post-operative length of stay is 6.9 days. And we have been able to reduce that by performing post-operative on-table extubation. What we've been working on in 2019 is this begins to dovetail with the concept of enhanced recovery after surgery. These are protocols that are directed at implementing multimodal analgesic therapies along with reducing the use of intraoperative narcotic as well as postoperative narcotic use. In 2019, what we have begun to do in 25 patients thus far, irrespective of the type of cardiac surgery, is we've been giving them preoperative gabapentin, the previous multimodal analgesic protocol, but prior to skin incision, we've been injecting in a chest wall block called a serratus anterior block, the liposomal bupivacaine, which has a duration of action of about 3 days. And what we have observed is we have further reduced our postoperative length of stay in all our cardiac surgery patients now to 4.6 days. We then compared that with all the patients that have undergone cardiac surgery since 2015, and we found that there is a halving in the length of stay in patients that have received these blocks. A corollary to this is the observation that our incidence of new onset postoperative atrial fibrillation has gone down from 35% to 8%. Thank you.
Thank you, Dr. Parmet. At this time, we'll now hear from Janet Cahill. Janet is from Einstein Montgomery. Janet, we'll hand it off to you. Janet, you might just have to unmute yourself. Janet, we just unmuted you, so if you want to take it away. Okay, we'll come back to Janet at a later time. We're going to move on to Julianne Jablonski. Julianne is from Penn Medicine. Julianne?
Hi there, everybody. Yeah, my name is Julianne Jablonski, and I am by background a critical care nurse specialist. I'm in the role of a systems critical care strategist, and my role is around integration of practice across the health system of Penn Medicine, which has 6 entities. So the work that we're doing today, if I'll take your eye to the left lower hand corner, is around critical care practice and implementation of what's called an ABCDEF bundle. Each individual piece of this bundle has a plethora of research showing benefits for decreased length of stay, decreased ventilator days, and all of the work around bundling this shows mortality benefit along with those other great benefits. The previous presentation really highlighted how the importance of getting off the ventilator as soon as possible. This work that the piece for this part of the presentation in this poster is really around getting off the ventilator as fast as possible. So these are all patients, it's both medical, surgical, all patients that are admitted to ICUs across our health system, and they're on the mechanical ventilation. And how do you get them off sooner? So the work around this had to begin with standardizing assessments across the 14 ICUs. And what I mean by that, there's standard assessments that nurses do every 4 to 12 hours. It's a RASS score, which is assessing your sedation / agitation level, and then delirium assessments. So implementing that was part of the first work. And as we all know, when you do new assessments, it's working it into the medical health record and such. The second piece was around standardizing mechanical ventilation weaning criteria. So across our health system, we have weaning policies around what is set criteria that a patient should be screened for weaning. And our respiratory therapists, once a day in the morning, usually between 7 and 9, will assess every ventilated patient for their readiness to do we call it a spontaneous breathing trial. And nurses are constantly evaluating a patient for decrease of sedation and analgesia. As you can imagine, that is a really factor in keeping someone on the ventilator if they're not breathing spontaneously. So it's that fine line between having an awake and interactive patient who is also comfortable. So as I'm saying this, you can imagine the complexity of this bundle, and hospitals across the health system struggle with bundle implementation. So what we tried to do to really put an innovative piece into identifying a patient's readiness for ventilator weaning. And when you now look at the top middle box, we have what we call an ICU board. And this is a computer application which takes all of these standardized practices that I spoke of, and after the clinician documents it in the medical health record, it will float into this live streaming board, which really speaks to the components of the ABCD bundle. Our work, and I'll tell you, we didn't get to the E and F yet at the time of this, but so it's really the A through D, taking all those assessments, and then there's an algorithm that the computer uses to say, oh, this patient looks like they're meeting readiness for spontaneous breathing trial and sedation weaning. So instead of waiting for the routine AM assessment that the respiratory therapist would do, the computer then will send out, not the computer, but the flow of technology is that an alert will fire to the bedside clinician's phone to say that the patient looks like they are meeting criteria to try weaning from the ventilator. And if they're on a continuous infusion and their sedation level indicates there's a need, then the nurse will get the text to say, listen, talk to the respiratory therapist. Could you potentially wean the sedation, and could you try a spontaneous breathing trial? So this technology, we tried to depict it a little bit up in that picture. So this went on for a year, and then as we get to the results of this, the first graph is just showing you the amount of continuous sedative infusions that we saw a decrease in following when someone would receive the spontaneous awakening alert. And we're seeing a gradual decrease in continuous infusions, which is part of our outcome measure. And then in order to make sure our algorithm was getting the right data, we had to even make sure that the nurses were assessing and entering their delirium assessments. So across the health system, we were 43%, and we've sustained around 93%. And even today, this data stops, I believe, around December. But even for the last 6 months, we're still sustaining. And then our RASS agitation assessments, we've sustained more around the 85% mark. So I do want to see that get higher. So between the documentation, the standardization, then the ultimate outcome was to see a decrease in our median duration of mechanical ventilation if you're following this bundled approach. So in the right-hand corner, you'll see that when you look at the second graph, it shows duration of mechanical ventilation. And now this is median, so it's going to take away all those big long-term outliers, but our median is only around a 2-day median. And after implementation of these alerts, we went down to a 1.6. So we've decreased a 0.4, which in the whole scheme of things in median was almost a 25% decrease in our duration. And then when you look at duration of delirium, again, it's a median. You can see that we had more fluctuation, and then we reached that steady point of a 2-day duration of delirium. So as we've, lots of lessons learned around sending alerts and accuracy, even just the idea of someone getting them on their phone. We're now working into building these alerts more into the medical records so that you don't have to rely on a phone to get this sort of warning, not a warning, but to say to the clinician, listen, now is an opportune time. Could we get to the patient now before waiting till the morning? And as we grow in our bundle, we're now doing more around early mobility, which really just started implementation phase of that about a month ago, where we're working with team dynamics and goal setting. And again, that standardizing practice and documentation about peak level of mobility as we pull this bundle together. So the board in itself, so in a summary, I think the big things we've done is we've standardized practice, we've integrated into our electronic health record, we tried to create a nice display of data so clinicians could make real live decisions in the moment, and then built-in nudges and alerts in our chaotic world to help with getting patients off the ventilator. And that's it. Thank you.
Thank you, Julie. At this time, we're now going to hear from Dr. Lim. Dr. Lim is from Abington Hospital, Jefferson Health. Dr. Lim?
Hi, thank you very much. This is Philip Lim. I'm the chair of radiology at Abington.
Dr. Lim, I'm just going to interrupt real quick. There's a little bit of a background noise. That sounds better.
Okay, great. So our project is to identify ways to improve follow-up of lung nodules that we see in radiology reports. And we've been doing this over a 3-year journey. And my role has really been trying to orchestrate and try and get this project up and running. So we had really the problem is, there's a lot of imaging findings in radiology reports that are usually incidental, and lung nodules falls into that category. And the problem really is to, communicate those findings to the patient, and then to identify which patients have or have not followed up, and then also to track these patients and to remind them that them or the patient's primary care doctor needs to get a follow-up, possibly for an imaging study. So this has been a chronic problem, I'm sure, at every institution. So we started off by using an off-the-shelf natural language processing software and to identify patients. So that was pretty good, but realized that we couldn't track them very well because it took a lot of time by someone to find out whether the patient had follow-up done and to figure out how to send letters or an email or some kind of communication method to these patients. So this is all being done on our billing company side, which is kind of unique. So our group is a private practice group in radiology at Abington, and we have our own billing company for professional services. So I had asked the billing company to consider using a software to track patients, and it seemed like a natural idea because they are really good at tracking small pieces of paper and findings and so forth, and have access to addresses of the patient as well as the primary care doctor. So soon after we started developing this project, we realized that we really need to make a customized internal software, and we did that over about a year and a half. And you can see the table of the results there, where back in 2015, just as a baseline, we saw that there was a very small number of patients who were identified for follow-up and who actually got follow-up. And then as our analytics started kicking in and identifying more radiology reports that need follow-up and sending out reminders and letters to the patient and to the primary care doctor, we saw a steady increase over the 3 years. So that's been, quite a great success. The real factors that made the project successful was that we had a steering committee internally by leadership from the hospital, and also including a chief medical officer, a chief information officer, the chief safety officer as well, and people from administration, like in radiology, as well as in the VP level of the Abington Hospital. And then we had a smaller working group, myself and the IT people from the billing company, who work pretty much every day or every few days to tweak the software and to see what changes need to be made. And the real part that made it successful was that I met with the primary care physicians and their nurse and their office managers to make sure they knew that this letter was coming to them and to their patients. And the chief of staff really emphasized to the primary care doctors that they would be the gatekeeper and would be responsible for determining whether a follow-up study needed to be done, even though the primary care doctor may not have been the one who had ordered the initial study. So that was a big hurdle to overcome. But everyone really agreed that the primary care doctor would be the best person to determine that, because they really had all the relationships with the specialists, as well as understanding what the patient's problem list was. So over the past year, we've really been busy with expanding the tracking program to include other organs like kidney, adrenal, pancreas, thyroid, incidental findings, for instance.
Okay.
We've also got it published in the British Medical Journal, Open Quality. So we have a full paper that explains in great detail what we've done here. And I think lastly, when we try and figure out how any organization could replicate our initiative, is that first of all, you have to identify your team, who's going to be the champions of this. You need some kind of identification software, like a natural language processing software. And then you need the manpower to start tracking whether the patient has follow-up, and this person may be a nurse navigator to go into electronic health records and start identifying patients and communicating in that way. And that's it. Thank you.
Thank you, Dr. Lim. At this time, we're now going to hear from Deborah Slavely from Temple University Hospital. Deborah?
Good afternoon, everybody. It's a pleasure to be able to present our work around creating an alternative care model for low acuity patients who were coming to the Temple University Hospital's emergency department. And overall, our interest in doing this was in looking at our neighborhood. We don't have any urgent cares available to our patients, and nearly a quarter of all patients presenting to the ED were low acuity patients. Low acuity patients tend to create overcrowding, which increases wait times, increases patient elopement, decreases satisfaction, and has been shown in the literature to negatively impact quality of care. So senior leadership was very interested in engaging in a system whereby we could reduce our low acuity visits in the emergency department. My role in this is I'm a director for the Temple Center for Population Health, and I was the lead evaluator for the project. We looked at logistic, clinical, and financial implications of what we did. We began by looking at the CMS multi-year study, where they identified through their outcomes 3 key strategies that would help an institution decrease inappropriate ED use. And what we chose to do was enter an engagement with a federally qualified health center that was located really close to our emergency department in the healthcare system. and were not only had the primary care that these patients needed, but a lot of the other support around behavioral health and social problems that we also see among our patient population. So the team engaged, and it took them nearly a year to create the process flow, the contracting, the billing systems, and what was really key here was the emergency department staff educating the providers in the federally qualified health center on how to deal with some of these low emergency problems that aren't typically seen or cared for in a primary care setting, such as splinting and those sort of things. So the process was that as a patient presented to the emergency department, if their ESI score was considered low acuity, that's the emergency severity index, and they met the predetermined criteria for patients that we were going to refer over to the federally qualified health center. They were immediately referred to a provider in the ED to screen them, to ensure that they were low acuity, and that allowed us to meet the EMTALA law, the regulations around hospitals and the requirements to care for everybody who presents to the hospital, irregardless of their ability to pay. And then the patient was offered care either at their primary care or at the federally qualified health center. Most chose the federally qualified health center, and they were escorted over to this center to be provided care. We looked at the first year of our outcomes, and we found that about a fifth of our patients presenting for low acuity were referred over. And the reason it wasn't statistically significant for us, but was in a positive trend, was that we had a low volume during the initial ramp up period, and then volume continued to grow. And that is on the slide in your, on the right-hand side, where you can see the volume growing through the year. We had no patients return for any critical or urgent problems to the emergency department. Our patient satisfaction for those who were referred over and received care outside of the emergency department was very high. Financially, we saw a $2 million savings for our third-party payers, which will, from a sustainability perspective, allow us to include that in some of our value-based contracting that we do. Our emergency department wait times decreased, but they had been decreasing, and that decrease continued to happen over the study period. And we found that while the federally qualified health center was open, we had a statistically significant reduction in elopements of our patients. What we did learn over the course of implementing this, that we needed to expand the hours of the FQHC in order to be able to move more patients over. And again, as per the graph, we were able to do that and have continued to see successfully an increase in the patients who are accepting those referrals. I think this would be easily replicable where you're having positive clinical, financial, and logistically, it worked very smoothly. As long as you find a good partner that will work with you to develop the systems and continue to track outcomes. I thank you for everybody's time, and I look forward to any questions.
Thank you, Deborah. And at this time, we'll now hear from Monica Nash. Monica is from Einstein Medical Center, Montgomery. Monica?
Hello, everyone. So today I'm here to talk to you about preventing opioid-induced respiratory depression in medical surgical patients. So we'll start with our why. I am Monica Nash. I'm the director of our medical surgical department here at Einstein. So our why story. We had a young woman who had recent abdominal surgery at a Philadelphia hospital. She woke up one night in severe pain. On her way back to the hospital, the Philadelphia hospital, the pain was so intense, she chose to come to our emergency room. She spent the night in the emergency room where she received several doses of morphine without success. She was admitted the next morning to our medical surgical department in intense pain. During the admission assessment, the physician asked her, "What exactly do they give you at the Philadelphia hospital to relieve your pain?" She answered 4 milligrams of Dilaudid. Our nurse came in, the physician ordered the Dilaudid. Our nurse came in and she administered 4 milligrams of IV Dilaudid to the patient. She left the room, and within minutes, the patient's husband came out into the hall and said, she's blue and she's not breathing. We coded the patient. She survived. She was transferred to ICU. As the director of the unit, it was my job to go up and meet with her and her family. We spent some time together, and as I was leaving, her mother looked at me and she said, please don't let this happen to anyone else. That's our reason why, and that's why we began this project. So I'd like to talk to you about some of the key factors that made this successful for us, because it was overwhelming at the beginning. First, we needed complete buy-in by our administration and our C-suite department, and they did. They supported us from the beginning. Second, first assemble a team. We built an interdisciplinary team for each step of the program, and some of the people that we included in that were physicians, anesthesia, pharmacy, risk management, quality, education, IT, respiratory, nursing, and of course the vendor. Vendor support was crucial. Our vendor partnered with us to provide education to the team and also to the staff who would be using the equipment. They were here the first week of rollout almost every single day. After that, they were there weekly, and they did provide us with 24/7 on-call support should we have any issues. We were completely successful. Some of the new developments we've had since that time, our project has been so successful here at Einstein that it's been decided that we will now use end-tidal CO2 monitoring on all of our patients throughout the hospital. That was a really big deal for us to begin in med-surg and now everywhere. Secondly, the staff now has a comfort level. We had developed an OIRD assessment tool that helped the staff to determine who needed to be on end-tidal CO2 monitoring. The staff, after several months, became so comfortable, they started to identify staff that needed end-tidal CO2 monitoring without the use of the tool. A very good example of that would be a patient that came in sickle cell crisis. As many of you know, they come in and they are on high doses of opioids. That makes people uncomfortable. Their priority is obviously to take care of the patient and keep them comfortable, but also they were concerned with the patient's safety. Being able to put them on end-tidal CO2 monitoring made the patients comfortable and made the staff feel safe with the decisions that they made. Something very recently that happened was we had a patient who needed to be discharged with a portable ventilator. In order for that to happen, they needed to have some overnight sleep studies, and time was an issue for that. Insurance was denying the patient to be discharged with a portable ventilator. We had enough data from the patient being on end-tidal CO2 monitoring while they were here that we were able to provide that to the insurance company, and the patient was discharged safely with the portable ventilator that they needed to go home. Another thing, you cannot put a price on a life saved. So many of our staff right now have wonderful stories to tell, and they support each other in it on the patients that they've put on capnography, end-tidal CO2 monitoring, and they've made safe recoveries. Finally, several members of our team are serving on a panel that's going to formulate an expert consensus statement. That statement will determine whether or not OIVI is preventable. We would be happy to share any of our information with you. We have some tools we've developed so that anyone that's interested, that would help you to replicate our initiative. Finally, we wanted to thank the Healthcare Improvement Foundation and HAP for the generous funds. We've been able to send many of our staff to conferences where we can share our success and find ways to have new success. So thank you all very much.
Thank you, Monica. Thank you for that wonderful presentation. And just a quick shout out, as you were the first place winner. So wonderful to hear from your team and about your initiative. Now we're going to jump around the slides just to keep you on your toes, and we'll hear next from Dr. Brad Bendesky. Dr. Bendesky currently serves at Mercy Catholic Medical Center. So Dr. Bendesky?
Yes, thank you.
Dr. Bendesky, we're getting a little bit of feedback. Yep, that's wonderful. Thank you.
Oh, sorry, can you hear me now?
Yep, we can hear you.
Sorry about that. I had both the phone and the computer on. So thank you. Sorry about that. I, I'm the director here at the emergency department at Mercy Catholic Medical Center here just outside Philadelphia. We have a sister hospital, Mercy Philadelphia Hospital in Southwest Philadelphia, and another sister hospital in Northeast Philly, Nazareth Hospital. And our approach to the opioid crisis was one that was challenging since we're not a tertiary care center and we have limited resources for our patients. And as many of these other presentations show, there's a lot of concern about the dangers of opioid use. And we took the approach to be as comprehensive as possible. And our submission here really is all of our initiatives put together into one program. So we have an opiate utilization reduction team that was formed about 1.5 years ago. It's a multidisciplinary team that is made up of literally a representative from every specialty, including nursing education, case management, quality, safety. And we did this because the 3 hospitals that are here locally have such a high incidence of opioid overdose. So what we did is we started with our prevention programs, and we started with an outpatient program that was led by our Sisters of Mercy, where our behavioral health nurses, pastoral care, go out to the middle schools in the area to present a program to provide support for students who have been exposed to the crisis around opiates. So a lot of these, what we found in our neighborhoods, a lot of the students had family members or friends who were affected by this. And what this community program did was allow the behavioral health team to teach the community about opioids, to educate them about our programs here within the hospital, and then to try and link those students and the families with our resources within the hospital. We followed that up by then, again, along the idea of preventing this, we initiated a program by which all of our healthcare providers get personal feedback on the amount of opioid prescriptions that they write. So not only in the emergency department, but also with our medical teams, get a report back and see how many prescriptions they are writing as opposed to their colleagues. Our team then rolled out for the nurses. They started to gauge how often patients were having their pain addressed, and started tracking how often patients needed to be redosed, and then provide educational materials for alternatives to opioids. One of the biggest things that we did, along with some of the other hospitals in the area, is because of the initiatives around medication-assisted treatment and buprenorphine and Suboxone. Again, us being a community hospital did not have some of the bandwidth specialty consultation services that some of the tertiary care centers have. So we did not have a defined addiction medicine team. We do not have a toxicology team. We rely on a lot of the tertiary care university hospitals in our area to support our community hospital. But what we did was we realized we had enough interested parties between the emergency department and with our internal medicine team that we created a buprenorphine or Suboxone induction protocol that we can initiate in the emergency department for all of our patients. And even though we don't have addiction medicine here, we partnered with local experts and with local recovery centers so that even though we may not have these services on campus, what we can do, we educated all our providers about Suboxone. We have a very comprehensive educational program that has been disseminated through both our physician teams and our nursing teams. And we created a one number referral that can be reached 24 hours a day. So our behavioral health team created a number, and we train staff so that if anyone walks into our emergency department or anyone is admitted into the hospital, they can then be tied in with the recovery team in a case manager. And after their medical treatment in the emergency department or their inpatient medical treatment, they can be then warmly handed off into a local recovery center. And what we did is we have a list of recovery centers that are convenient for our patients. So my list here at Mercy Fitzgerald is different than the list over at Mercy Philadelphia, which is different from the list over at Nazareth. And along with this, after we promoted this, we use this one number resource to, and we offered it to even our primary care doctors. So if they have a patient within their office who needs help with opiate use disorder or substance use disorder, we encourage them to call that one number. And since this is a fairly new process to do medication-assisted treatment, and some of the complexity with insurances around trying to get patients into recovery, this one number resource kept all of those details isolated and siloed into an expert's review. And the benefit is that any of our providers, any of our nurses, any of the community members that were involved with the Sisters of Mercy lectures over at the junior high could call this one number. And if they had questions about substance use disorder, questions about what to do, whether they were in withdrawal or not, or just looking for information, they can call that number and get that information from one of our experts. So this is one of those things that we're proud of because we tried to spread such a wide net, and we continue to recruit members into our opiate utilization reduction team. We started with just a handful of people, about 5 people, and now we have probably 25 or 30 people that serve on the committee specifically, and we have hundreds of people, staff members who are now involved and offer to disseminate some of this information. And we've created champions up on the floor that take this information, and they now teach colleagues at all levels, including nurses and techs. So this is something, again, that we're proud of, coming from a community site and trying to throw a very wide blanket and support around our community. And we're finding that it's been more successful than we even imagined when we first thought of this.
Thank you, Dr. Bendesky. At this moment, we just want to acknowledge it is 4 o'clock. We hope you'll be able to stick with us. We have one more presenter. Janet Cahill from Einstein Medical Center, Montgomery, will be our final presenter. Janet, if you'd like to take it away.
Yes, my name is Janet Cahill. I'm the clinical microbiologist at Einstein Medical Center. We in the laboratory were looking for a very rapid and accurate pathogen detection test from positive blood cultures. There were various different systems on the market, but we wanted to get one that would have very accurate, rapid results, easy to perform for all our personnel. And that was our quest. Part of our support came from our Antimicrobic Stewardship Committee. We have a very active stewardship committee here at our hospital. We have a very close relationship with our clinical pharmacists, and we appreciated any input they had on our quest to find a good system. So with their support and involving them in our different learning and lunch and learn from the different systems, we've selected a PCR test that would give rapid results in the positive blood culture bottle within 1 hour after turning positive. It was very easy to perform, and we trained all of our lab techs, including those working on second and third shift. That was key. So any time any person in the entire lab on the shifts would be able to do that critical test. The key element of our testing procedure was, of course, to involve the pharmacy 24/7. Without doing this, we felt we would not accomplish our goal, which was to have better patient outcomes with appropriate antibiotic treatment. So using a logarithm that the pharmacy developed, they have that information. So when the laboratory tech calls the pharmacy, they will then contact the provider with recommendations on how to optimize the appropriate antibiotics for that specific organism that was detected. Doing this, we found that our patients would receive, on the average, 25-hour earlier, better appropriate antibiotic treatment. Our recommendations were very well received. We avoided unnecessary treatment with vancomycin in 60% of all cases when we've had an isolate that was deemed to be a contaminant known as coag-negative staph. Therefore, no treatment was given, and they recognized that this was just a skin contaminant. We also found that through our procedure process, we were able to confidently de-escalate to one antibiotic treatment for septic patients. And 97% of the time, our clinicians accepted and used our recommendations. A really high point of our procedure was within the first 4 months of bringing this test on board, we saw a reduction of 1.5 days for bacteremia with a cost avoidance of $322,000. This test we've been using this test now for the last 2 years, and we continue to have this integrated in our daily workflow. It continues to meet our expectations, and we are still seeing, which is a very key element of our initial project, was that we see better improvement with our septic patients, and we also are continuing to see a decrease in our hospital costs. And I would like to just say that all our staff was so enthused with this test. They eagerly learned it and accepted it. Our pharmacists, the same. We had no resentment as to adding to their busy schedule. And we are continuing looking at the data. And at this time, it is exactly the way we thought that it would improve our hospital. And I thank you for your time. If you have any questions, just let me know.
Thank you, Janet. At this moment, we don't want to keep you too long, so we're actually going to postpone the Q&A. We do have some questions that were posed, so we'll be sure to answer those offline. You can be sure to receive those in my follow-up email. We thank all of our presenters as well as the attendees for joining us today. We're pleased to announce that the 2019 call for entries is currently open for submissions, and we look forward to seeing your organizations and teams submit for this year's program. I will be sure to be in touch with my follow-up email, and thank you for your time. Goodbye.